The Michael Berry Show.
My urologist, Dr. Mohit Khera, is our guest. Welcome to the program, good sir.
Thank you, Michael.
Everyone has a lifespan, Ramon. You know that. You have a lifespan. We talk about our lifespan. Dr. Mohit Khera is writing a book called, or about, the sex span. How long can a human being have a functional, fulfilling sex life? Dr. Khera, why does that matter?
Well, Michael, first, thank you for having me on the show. You know, everyone where you go everywhere talks about lifespan and health span. That's the big buzzwords in the community. And I'll give you an example. Everybody wants, I assume, their health span to last as long as their lifespan. But in the United States, the average health lifespan is 77 years old. Women live typically 79 years old. Men live typically 75 years old. But the health span in the United States is roughly 67 years old, which means most of us, for the last 10 years of our life, are not going to be living in a healthy condition, which is very unfortunate. And all these countries talk about how they're expanding the lifespan and getting people to live longer. In my mind, that is not what I want. Do not expand my lifespan without expanding my health span. But this concept of sex span is also important because many men would say, look, I said, if you're going to live till 80, but you can only have sex till 50, that's a problem for many men. And so what we want to do is try to expand our sex span and our health span as long as our lifespan. And I think that's a really important point.
I know one of the things I like about you is that you don't just rely on what you learned in medical school and then mail it in every day. You're constantly reading studies. You're constantly performing research and publishing and speaking literally around the world because you're always somewhere else when I call you just to see what you're up to, giving a speech on this or that. How important is sex to the human body in terms of purely physically?
Yeah, it's extremely important. So I want to just clarify one thing. Erectile dysfunction is not a disease. It's a symptom of other underlying diseases, right? So ED does not happen in healthy men as they get older. If a man gets erectile dysfunction, it is a symptom of his diabetes. It's a symptom of his cardiovascular disease. It's a symptom of his radical prostatectomy or surgery, or it's a symptom of depression or anxiety. So when someone develops erectile dysfunction, the second question you should be asking is, what else is going on that's causing this condition? Because if he was perfectly healthy, that would not happen, right? And so the best example I can give you is this, is that did you know that if a man walks in today and has erectile dysfunction, 15% of them will have a heart attack or a stroke within 7 years? 15%. It's an underlying marker of cardiovascular disease. If a man walks in with ED today, 30% of them have occult diabetes, 30%, which is a lot. And if a man walks in today, 30% of them will have depression or anxiety. So the biggest mistake I can do is give this man Viagra and send him on his way because maybe he has that occult cardiovascular disease. Maybe he has diabetes. Maybe he's suffering from depression or anxiety. So it's really important to figure out what is causing that ED. And what's so nice about this is that there's a bidirectional relationship. So if I treat a man's ED, that actually improves his depression. If I improve a man's depression, it actually improves his ED. So I think the paradigm is shifting. No longer do I want to just hand the man the pill. You got to figure out what's going on underneath because this is what I call the canary in the coal mine. And you can actually save someone's life. I mean, imagine if I catch someone's cardiovascular disease today or diabetes today, or I catch it 10 years from now, it's a total change in trajectory in terms of their health span and their life.
Well, it goes back to Viagra originally being a cardiovascular disease and a off-label benefit being the ability to get erection.
Yeah, Michael, that's a funny story because remember this, they were trying to make a blood pressure medication and accidentally everyone in this study was getting erections, and they figured it out because people were not returning the pills.
I had a friend. I was a baby lawyer at the time at a firm called Jenkins and Gilchrist, and I worked with a guy named Darren Alt, who was my best friend there, and his wife Tracy was the head of Viagra in Houston, which was the top market for Viagra in the country. And they were taking a trip every other week with their sales reps, and they had all sorts of stories of people. And at that point, it was still you'd go to your cardiologist to get Viagra. So everybody was faking a heart problem to go in and get this medication. And the story
Right.
goes that the doctors were getting calls from the wives going, "Hey, knock it off. Take him off of that."
Right. Yeah, absolutely. And so, you know what? The issue is that ED back then was not considered a very serious condition. People used to make fun of it and, oh, he has ED. ED is a very serious condition. Someone gets erectile dysfunction, take it seriously. Something else is going on.
Well, and to oversimplify this, that is because it means you're not getting proper blood flow, or you're not pumping your blood properly, and that's, I guess, as good a way as any for us to check. Maybe the easiest way.
Yeah, and so think about this. I teach the medical students this mnemonic called VENT. Vascular, meaning there's not enough blood flow coming in or there's too much blood flow coming out. And too much blood flow coming out is the most common cause of ED. So the guy will tell you, I can get the erection, but I just can't maintain it. He's telling you the blood flow is coming out too quickly, the number one cause of ED in the world. But VENT stands for vascular. E means endocrine. It's testosterone. The testosterone goes low, ED goes up. Neurologic, meaning nerve injury, and then trauma. And don't forget medications. Medications are notorious. For example, beta blockers. How many people are on beta blockers? Shuts down the erections. Antidepressants shuts down the erections. So you got to look at all the different causes for ED. And I just want to stress one other thing. Sexual dysfunction is a couple's disease. You know, we're so fixed on these silos. I got to take care of the woman. I got to take care of the man. You got to look at both of them. I'll give you an example. Back in 2007, I finished my fellowship, and I was so proud of myself. I was able to get these men these amazing erections, amazing libido. And one day, a woman called me and said to me, she said, everything was great with our relationship until he met you. We never fought. We fight all the time because every day he wants to have sex with me, and I don't want to have sex with him, and you've ruined our relationship. And I thought to myself, she's right. What is the point of raising one libido without raising the other? Either leave both libidos low. It's fine. Leave them both low. Or raise both. But you don't raise one without the other.
Dr. Mohit Khera at the Baylor College of Medicine and my urologist and friend coming up. The book will be, I got to get the name of it. It's about the sex band. Maybe call the sex band, Ramon, you know? It's a hard problem to talk about.
Everyone listens. The Michael Berry Show.
Dr. Mohit Khera is at Baylor College of Medicine, where he is a urologist. He has a forthcoming book. Is the book called The Sex Span, Mohit, or what is the book called?
It is called Sex Span, and it's a proactive approach to prolonging your sex span.
So, as we were going into the break, you made a statement about if you help a man build his libido and his sexual function, but you do not concurrently do that for the woman, you end up causing problems for them. Let's take the physical out for a moment. In your opinion, how important is sexual relations to a couple and to an individual emotionally? You tied it to the antithesis of depression, but talk about that if you would.
It's extremely important. If you look at couples that engage in regular sexual activity, they tend to be happier, overall satisfied with their quality of life. They usually tend to be healthier, and they usually tend to live longer. So there are numerous aspects. There was one study that I saw that talked about couples that who do not engage in sexual activity typically can have a twofold detraction from their relationship. But if they do engage in sexual activity, it actually can add 4x to the quality of the relationship. So, let's be honest. It does bring intimacy and closeness to the relationship. It does strengthen the quality of the relationship. And in many cases, people find this extremely important. So I do think that there is medical benefit, psychological benefit in patients engaging in sexual activity.
I have had friends over the years who, when they put their parents in old folks' homes, they talk about how how it is surprising how much activity there is in the old folks' home. And when I did that for my dad earlier this year, that was one of the things that everybody consistently across the board talked about. I don't know if there's anything to that, but we're talking about people in their 80s and 90s, and I have heard this story consistently.
You're actually right. So one of the highest levels of STDs do occur in nursing homes. So you do know that there is increased sexual activity that does occur in those nursing homes. And so, but part of it is because at some point there's an inflection point. As you live longer and longer, those patients that are the healthiest tend to live the longest, and those patients who tend to be healthier tend to be more the ability to engage in sexual activity.
When you and I talked about the book the first time, you said that one of the things that the book is going to cover is the importance of screening for testosterone and how erectile dysfunction is a marker of other underlying major medical conditions such as a heart attack. The screening for testosterone, why is that important?
So, Michael, I am very passionate about this topic because, everyone thinks about testosterone as energy and sex drive and erections. And yes, it's true. If you have low energy, low libido, erectile dysfunction, giving a man testosterone can improve these symptoms. But now we're in an era where it goes way beyond that. So did you know that a man who has low testosterone is much more likely to have a heart attack? Non-negotiable, much more likely. A man who has low testosterone is much more likely to break a bone. A man who has low testosterone is more likely to have diabetes, obesity, metabolic syndrome. A man who has low testosterone is much more likely to suffer from depression. And giving a man back his testosterone can help mitigate or improve these conditions. So it's not just about sex. It's about your overall health. The problem I have is that when I walk into my primary care doctor's office every year and he checks my blood, he does not check an annual testosterone. He'll check a thyroid. He'll check a TSH. I say, why are you checking a TSH? He said, well, we do that every year to make sure you're not hypothyroid. There is not a better marker of a man's overall health than a testosterone level. It gives you a marker of what his health is today, and it gives you a marker of what his health will be in the future. And so every man over the age of 40, every single man should be getting a testosterone level every single year after the age of 40, because I do think it's the best predictor of his overall health currently and in the future. And it's modifiable because there's things I can do to improve his testosterone if he's low.
You suggested testosterone for me 10 years ago. I know you weren't going to talk about it because you're the doctor, but I can. Obviously, it changed my life. It made a huge difference for me. But when you do that for folks, what kind of differences do you typically see?
Well, the first thing you have to ask yourself is, are they young and do they want to have children? Because most people don't realize that giving testosterone actually shuts down your fertility. So I can't tell you how many patients I see in my practice every week that said, look, I was started on testosterone, or no one told me that the testosterone could make me infertile. Now we want to have kids. What do I do? So there's ways I can reverse it. So the reality is, if you're in the reproductive years, if you're planning on having children and your T is low, don't take testosterone, but let me give you medications that make you make testosterone. That's safe. So I can give you medications to make you make testosterone, and that will enhance your fertility. But if you're older and you're not trying to have children, then there are many ways to give a man testosterone. We now have oral testosterone, which is fantastic. Oral testosterone is very new in the United States. It's only been out for 5 years. And now we have a pill, we have injections, we have pellets, we have patches. But I will tell you that I do think that this medication can have a profound effect on the quality of life in many patients. I mean, many patients come in, they're thanking you, they're telling you that they have a significant improvement in their erections, their libido, muscle mass. Not everybody. I mean, there are patients that don't respond. But the majority of patients who start out low do see a significant improvement in their quality of life.
I was talking with one of our show sponsors, Wayne Wilson, who owns Synergenics, and he said, hey, your urologist is the one who came when we started, I guess, with pellets or whatever, and came and talked to them about testosterone, and obviously that's what they do all day, every day. And he went through the various things that you talk about. I mean, he took note. He's a physician's assistant by training, but it was amazing to me. You were the god of testosterone as far as Synergenics is concerned, and I didn't know you had an association with them.
No, I appreciate it. I mean, I have been very passionate about this for about 25 years. So all my basic science work, all my lab, all my clinical trials are around this topic. So when it comes to teaching and education to others about testosterone, I'm all in.
Mohit, can you hold with me for just a moment? Dr. Mohit
Sure.
Khera is our guest. He's at Baylor College of Medicine. And I'm going to start with the question everyone always asks, well, am I more likely to get prostate cancer? Michael, aren't you worried about prostate cancer? We'll ask him that coming up.
With his finger on the pulse, the King of Ting continues on The Michael Berry Show.
Dr. Mohit Khera, my urologist and friend of Baylor College of Medicine and international renown as a speaker on issues of sex, urology, testosterone. Forthcoming book is called Sex Span, which talks about the length of time in which a person has a functional sex life. That will be out relatively soon. Dr. Khera, I received an email from a fellow named Doug who writes 3 minutes ago. I figure your interview is pre recorded, but if not, I'm curious about blood clots. I had a pulmonary embolism and they told me to stop taking testosterone. I used to go to the low T center and had a great experience with the treatment. I miss it. I hate that I can't take it anymore. Does Dr. Khera have a thought about that?
I do, Michael. So listen, there was a concern for that in 2015, and the FDA asked to conduct a large trial. It was called the Traverse trial. I was fortunate enough to be involved in that trial with myself and 8 other physicians, and we designed this trial. It was several hundreds of millions of dollars, and the goal was to see if it caused an increase in cardiovascular events and prostate cancer. What it did find was there was no increase in heart attack in those men taking testosterone versus placebo. We had over 5,000 patients. We followed them for 4 years. And there was no increased risk in DVT, but there was a slight increased risk in pulmonary embolism. And the difference was a difference of between 0.5% and 0.9%. So there was a slight signal. And I think it's very important to counsel patients when they ask about that. So I guess, again, I don't believe that, I personally don't believe that testosterone increases the risk of DVT and pulmonary embolism. I think the difference was small, but the Traverse trial showed what it showed. Also, I just want to mention it showed no increased risk in prostate cancer and no increased risk of worsening of urinary symptoms. Great study, Traverse trial.
Why do you think this is out there? Because I have a friend who started on testosterone. I heard me talking about it. He starts on it. 3 months later, he gets prostate cancer. He text message that says, "Hey, just want you to know, I just started on testosterone and I got prostate cancer. You need to be careful." And my immediate response was, "You haven't been on testosterone long enough, even if it did cause prostate cancer, for it to have caused that." If there was no testosterone supplement out there, men still got prostate cancer at large rates. You can't blame every one of them on testosterone.
I absolutely agree with you, and I got to tell you where it started from. It started in 1941 when Huggins and Hodges published their famous paper on showing that when you give a man testosterone, it increases the risk for prostate cancer. If you and I go to the library right now and pull that paper, you're going to find something very interesting. It was based on one patient, 1941, and it's instilled fear in us for so many years. The good news is, in 2018, my society, the American Urologic Association, said testosterone does not increase the risk for prostate cancer. Strong recommendation. So we do not anymore have a concern that testosterone increases the risk for prostate cancer. I'll tell you a very interesting story. If you or I had metastatic prostate cancer all over our body and we walked into Johns Hopkins University today, there's a trial where they put us on high doses of testosterone to reverse the prostate cancer, and it works. It reduces the PSA, reduces the metastatic disease. So we're learning a lot about testosterone prostate cancer, and this concept that testosterone increases the risk, I think, to me, is a myth. Michael, I want to bring up one other important thing. You talked about this earlier about testosterone, and you said when you give testosterone, does it make people feel better? But I tell patients that, you got to understand there's something that's just as important. It's lifestyle modification, diet, exercise, sleep, and stress reduction. I don't have a pill on the planet stronger than diet, exercise, sleep, and stress reduction. And every day when we wake up or when we go to sleep, we should ask ourselves, what are we going to do on diet, exercise, sleep, and stress reduction? I call that offense. Like 4 things on offense, and then I call it 4 things on defense. Only 4 ways you and I are going to die. We're going to get cancer, we're going to get a heart attack, we're going to get metabolic disease, meaning diabetes, obesity, or we're going to get Parkinson's or Alzheimer's. So on the defense, every day we should ask ourselves, how are we going to keep those 4 things away? And on offense, how are we going to move our health forward with those 4? That, I think, is a really important point I wanted to get across. We have a big program on that. I mean, every time someone comes in, I have a program for their offense and defense. It's really important.
the four on offense, which you have preached since the day I met you: diet, exercise, sleep, and stress reduction. And do you have four on defense?
The four on defense are absolutely. So it's cancer, which means it's a heavy cancer screen, colonoscopy, PSA. Sometimes we'll do imaging as well. There are new tests that come out called Gallery. There are other. It's called a liquid biopsy test. I mean, there's ways to image and to look for patients who may have potential cancer. Cardiac screening is extremely important. You can sometimes, you'll get certain labs like ApoB, LP(a). Sometimes we'll get a coronary calcium score to look at the heart to make sure there's not increased calcium. Metabolic disease, you want to make sure that patients are watching their sugars. It's a silent killer. Sometimes we'll put a CGM, which is a continuous glucose monitor, on them to help them look at their sugars to make sure that they get the feedback to say, these are the foods I should stay away from. And then, there's not a lot you can do with Parkinson's and Alzheimer's. There are certain tests that you can look at, some genes you can look at to see if you're a higher risk. But, if you are at a higher risk, you can start altering your behavior, exercise, and doing things. So it's really important to keep the bad things away and use the diet, exercise, and sleep and stress to move your health forward. And that paradigm, most people get the concept of offense and defense, 4 and 4, and it's really worked well for a lot of my patients.
I don't know if I've told you this. Dr. Mohit Khera is our guest, Khera. It's at Baylor College of Medicine. I don't know if I've told you this, but on Christmas Eve, Ramon got a CGM, a continuous glucose monitor, and he started monitoring his blood sugar. And he keeps his blood sugar at a very steady between 1 and 130, usually about 115. The first thing I do when I walk in the studio every morning, because he's already here, is I ask him for the number. He sees me coming up the stairs, and he will write it down and show it on a sheet of paper or open the door and tell me. And it has absolutely changed not only his health, but his mood. I mean, he is consistent. He can work harder. He can work longer by just stabilizing blood sugar, which obviously for most people is fluctuating with great volatility.
I love that story. I think that's and I see that all the time, because the reality is there are foods that you're eating that you think are healthy and they're not, and the foods that you think that are not that healthy are. I put a CGM on my wife, and we went to the same restaurant once. We ate the exact same thing, and we got totally different numbers, because part of it's also genetics, right? So that can play a role in it as well. But learning more about what is bad and what to stay away from is extremely important, because if you give yourself feedback, and those who take feedback very seriously, you can really alter the quality of your life, because that sugar is just pounding the blood vessels, just pounding them.
My dad's a lifelong diabetic. He was 19 when he got diabetes. He's 85 now. It's amazing. He has all 10 fingers and toes, but he has monitored. I've had doctors tell me, your dad knows more about diabetes than we do, because he had to treat it before there was insulin. But I take Ramon to see him last week, and all they talked about was their CGMs and their Dexcom CGM and what the reading was and what this was and what that was. It was pretty funny to watch. Hold with me for one more segment if you can. Dr. Mohit Khera is our guest.
Sure.
The book is The Sex Span, and we will double back to that subject coming up.
From Portland to Albany and all great cities in between, The Michael Berry Show is nationwide.
Dr. Mohit Khera is our guest, Khera. He is my friend and my urologist and an expert in matters of sex and testosterone. I will read to you an email from one fellow says, let me go back to that. Another fellow, actually several fellows said, my wife's libido is way lower than mine. How can he increase a woman's libido?
That's a really important point. So, I told you earlier that couple, the woman that called me that was very upset. So in 2008, I actually flew out to California, did a mini fellowship in female sexual dysfunction, and I started treating women for the past 17 years, because you can't just treat one person without treating the other. And when you improve both libidos, it's synergistic. So women, it's female sexual dysfunction is comprised of 4 components: low libido, poor arousal, meaning poor blood flow to the genitalia, orgasmic dysfunction, or pain with sex. If she has any one of those four and is bothered by it, she suffers from female sexual dysfunction. And there are many treatment options out there. One could be hormonal. One could be actually using new 2 FDA-approved medications are out. One's called ADDY, A-D-D-Y-I. It came out in 2015. FDA approved strictly to increase a woman's desire for sex. That's it. She takes the pill every day. It increases her desire for sex. Vyleesi came out several years later. It's an injection EpiPen. She injects strictly to increase her desire for sex. Now, I just want everyone to be very clear. Libido is more deeper than that. I mean, there could be a lot of other factors. I mean, it could be her stress. It could be her physical condition. It could be fatigue. So you can't. It could be the quality of the relationship. So I mean, if someone has a terrible quality in a relationship, I can give them all the pill they want. It's not going to help. So you just got to look at the whole big picture. But I still also believe when you improve a woman's diet, exercise, sleep, and stress, her libido does go up.
It also helps if you take them to the movies.
Yeah, that's true. That's true.
Ramon,
but,
this is why we can't have
problem.
serious conversations. Alex
Michael
writes, Czar, what if you can't always afford the treatment for testosterone? Is there a safe supplement I can take that would help?
So the good news is that you can get testosterone even compounded. Compounding pharmacies, many of them are called the 503B, which are heavily regulated. They make testosterone at a price of about $30 a month without insurance. Most people can afford $30 a month without insurance. If you look at even medications like Cialis, if you use a good RX coupon card or you use Mark Cuban's company, you can get 90 days for roughly $20 or $25. 90 days for Cialis. So these medications are extremely affordable, and price should no longer be an issue.
That's interesting. Several of the questions relate to hemoglobin, blood thickness. I know some people begin giving blood once they get on testosterone because their blood thickens. Your thoughts on that? Is that problematic, or is that just a side effect?
It can be, and it all depends on what type of formulation you're using. Injectables have the highest rate injections, up to 66%. A pellet's about 35%. A gel's 12% risk, and a pill is about 5%. So if your hematocrit goes up, the number you want to remember is 54. If it gets above 54, there's a slight theoretical increased cardiovascular risk. And in my practice, we have these patients start donating blood. We don't wait till 54. We have them start donating at 51 because I don't want to wait to 54. So it is real. And remember that many of these patients have sleep apnea, occult sleep apnea, and the testosterone is unmasking it. So send them for a sleep study because you'll find that many of them are just suffering from sleep apnea.
I find a lot of people are suffering from some sleep disorder, and they've just grown. They don't even realize what a contributor to their overall health or lack of it that sleep is. It's almost always accompanied by the person being overweight, or maybe the overweight led to the sleep. But that's one of those things that I find when I dig into, people often have bad sleep, and they don't realize how important that is.
Michael, you're so right. Listen, when I take care of a lot of CEOs, a lot of people, and I talk about the 4 pillars, diet, exercise, sleep, and stress, they're all pretty good at diet. They're all pretty good at exercise. They're lousy at sleep and stress, right? And sleep and stress are so critical. And you think about sleep, it is a game changer. Even the way you think about sleep, it's not the hours you sleep. That's multiplied by how efficient you slept. So if you slept 8 hours last night, but you were 20% efficient, and I slept only 4 hours last night, but I was 80% efficient, I'm going to feel a lot better than you, right? So the reality is it's not just lying there with your eyes closed. You have to get good deep sleep, good REM sleep. And even 30 minutes extra of either deep sleep or REM sleep every night, game changer for the next day. So I think people need to be very militant. Just find a way to make sure that you go to sleep on time, wake up on time. And the best website I found was the American Sleep Foundation. The American Sleep Foundation has 20 tips on their website. They're awesome. Follow those tips. It makes a big difference.
Salt in the diet. So I've been reading a lot on salt lately, and I've not run this by you yet, so I'm curious to see if what you think of this. And the theory goes that we were told to stay away from salt. Salt raises blood pressure. Salt causes all these problems. And it basically the point of the piece was that we are now deprived of salt. And what do you do to treat someone for a number of things is you give them salt. Your thoughts on salt intake?
So I think that I'm still a believer that salt, particularly in patients who have hypertension, is a risk factor. And so if someone has hypertension, which many Americans suffer from, that is going to be something that's the first thing I'm going to ask them to stay away from. As a urologist, the other thing we worry about is increased salt intake significantly increases the risk for kidney stones. And so I am not a believer yet that we should be increasing salt unless there's a reason to do so. But I'm more concerned about the hypertension and the stone risk.
But on French fries, it's okay, right?
Sometimes. Sometimes.
Dr. Mohit Khera, you are the absolute best. The 4 phases of offense he has outlined are diet, exercise, sleep, and stress reduction. All things you can do yourself that don't require spending a dollar. Diet, exercise, sleep, and stress reduction. His 4 pillars of offense and defense. I cannot help you get in to see him, so don't even try because I'm going to be overwhelmed again. It's Baylor College of Medicine. It does take a while to get in to see him, only because he's very popular. A lot of people like him. I was my own worst enemy in sending too many patients to him at the beginning, and he only has so many hours of the day. The book is The Sex Span, which is not out yet, but will be hopefully soon. And when you let me know that is the case, we will all go and buy it online.
Will do. Thank you so much, Michael.
You're the best, my friend. Dr. Mohit Khera. Khera, Baylor College of Medicine. Yeah, so I'm having dinner at Gringo's, the new location at 99 and 249, with Wayne Wilson, who's the founder of Synergenics. And he was telling me about, we were talking about the testosterone replacement, but he was talking about this doctor, and he said, I think he's your doctor. He comes out and trains our people on testosterone and the effects and why it's important and all that. And it was Dr. Khera, and I did not know that. I had no idea. Dr. Khera was the first one that put me on testosterone. We did the pellets for a couple of years. And then Low T Center, which is also Synergenics, became a show sponsor. So I just moved over there and started doing the weekly shots. I like the shot. I like the shots better than the pellets. Some people like the pellets. I got to tell you my pellet story. Hold on.